Hello, everyone, and welcome to another Rafael Medina virtual morning report. Today, the topic is infectious disease, and we are very, very excited to have two physicians from Columbia University in New York, Dr. Jeff Paer and Dr. Marcus Pereira. Dr. Pereira, would you introduce yourselves and tell us an experience you've had together?
Yes, absolutely. You wanted for us to introduce each other, is that right? Okay. So first of all, I'm Jeff, just so we don't get confused, but I'll be introducing Dr. Pereira. So Dr. Pereira is an associate professor of medicine and the medical director of transplant infectious disease at Columbia University Irvine Medical Center. I had the privilege of working with him on the transplant ID service as an elective, as an intern, and then presenting a few cases to him as the night intern. And just a quick story I wanted to share about Dr. Pereira is that I once admitted a patient who was a liver transplant recipient who was being transferred from an outside community hospital to our institution for polymicrobial sepsis. And the patient had blood cultures that were positive for a few organisms that I had never heard of before, nor can I even remember their names today. And when I consulted Dr. Pereira, he said something to the effect of, wow, I've never heard of these bugs, but this is why transplant ID is so cool. And it was really this one sentence that showed Dr. Pereira's humility and intellectual curiosity, which is something I try to approximate every day.
Wow. Oh, well, thank you, Jeff. Well, as you know, I'll introduce Jeff. So Jeff is a third-year medicine resident at Columbia University. I've known him since internship, and he is actually a rising chief. So next year he will be staying with us for a fourth year as a chief, which is a true honor and actually a very well-deserved honor. Jeff has been an outstanding resident, and I met him. I think it was your first rotation as an intern, I believe. So he expressed a desire to rotate with us on a consult service for transplant ID, and he's sort of a stellar person. He, in fact, actually, his presentations were so polished that a number of people would pass by and think that he was the fellow already on our service. So I've known him for the last several years, and he continues to grow as a physician, and it's just incredible to see him at the stage. So I hope this will be a fun session, and looking forward to it.
Wonderful to hear from you both. Dr. Pereira, why is infectious disease the best specialty out there, and why should trainees go into that specialty?
Easy answer. So it's, in some ways, it's sort of the essence of internal medicine, right? To sort of, think about the differential diagnosis, take a superb, or thorough history and perform a physical exam, and not sort of overlook slight details, which I know this sounds cliche and you hear this often, but there are times when those are the key details and the key elements of sort of solving a case, or at least sort of, treating someone. And more than any other subspecialty, I feel at least that, sort of infectious disease encompasses all of those things that brought me to internal medicine and keep me interested in the profession on a daily basis. It's also the diversity of the cases, the diversity of populations that we care for, and in some ways sort of, some populations that are generally disregarded or ignored by sort of, in some ways, other sort of more established sort of specialties. So there's a sense of social justice that's sort of, essential to infectious disease as well. So it's just a combination of a number of really incredible elements that really makes infectious disease always a thriving subspecialty. And I think nobody here needs to sort of hear about how pandemics, are sort of, infectious disease doctors are essential in pandemics. So I hope that many of you are interested in this.
Love to hear it, and I'm sure many of the listeners will be convinced by your spiel on infectious disease. Dr. Paer, do you want to start with the intro to the case?
Absolutely. Let's get started. So first off, I'll just preface by saying that the patient provided verbal informed consent to discuss her case this evening. Okay, so for the first aliquot, the chief complaint is acute-on-chronic cough and fever. And this is a 46-year-old woman with rheumatoid arthritis and Felty syndrome. Yeah, 46. So I'll just jump into second aliquot, just because this presentation could open up a broad discussion, but I'll just give you some more information. So for this next aliquot, I'll provide some pertinent past medical history and then segue into her HPI. So she was diagnosed with seropositive erosive rheumatoid arthritis about 10 years ago. She was on methotrexate initially, but self-discontinued. It was lost to follow-up. And she reestablished care 3 years ago. She was reinitiated on methotrexate, but then self-discontinued 2 years ago. Even off the methotrexate, she was found to have pancytopenia with neutropenia. And so she was referred to hematology for further evaluation and was ultimately diagnosed with Felty syndrome, given her seropositive rheumatoid arthritis with erosive joint changes, neutropenia, and cross-sectional imaging noting hepatosplenomegaly. And so she had actually been doing well overall until 1 year ago, when she developed chronic dyspnea on exertion and non-productive cough, with numerous admissions in a comprehensive workup that ultimately resulted in a diagnosis of pre-capillary pulmonary hypertension by right heart cath. And so she was presumed to have pulmonary arterial hypertension related to rheumatoid arthritis, which started on medical therapy and had some clinical improvement. And I'll just mention, as part of this workup for these pulmonary symptoms, she had a CT chest without any pulmonary infiltrates. So despite her Felty syndrome, she did not have any infectious complications other than recurrent shingles, her last episode being 6 months prior. So getting into the HPI, a few weeks ago, she went to the ED for sore throat and left ear pain. Reportedly, she was afebrile, hemodynamically stable, maintaining well, without any evidence of acute otitis media. No labs or imaging were obtained during this ED visit, but a week prior to that ED visit, she had outpatient labs that noted an ANC of 320. She was discharged with amoxicillin clavulanic acid, but self-discontinued after a few days of feeling better. In the week leading up to her presentation, her chronic cough became more frequent and productive for the first time. And she developed high fevers at home for a few days, accompanied by myalgias, fatigue, worsening dyspnea, and epistaxis with an episode of small volume hemoptysis, prompting her presentation to the ED.
Thank you, Jeff, for the section. Dr. Pereira, before I ask you about this case, I'm interested to hear, what is your approach to patients who are neutropenic, or what organisms are they susceptible to in comparison to the general population?
Yeah, so so one is the definition of neutropenia, right? So is it 500 or 1,000 neutrophils per cubic milliliter? There's certainly a different sort of definitions of that, but certainly a sort of severe neutropenia would be anything less than 500. And some of your clinical thoughts on what they're sort of at risk in terms of which infections. Some of it depends on how long you've been neutropenic for, right? We tend to think, for example, sort of chemo-related neutropenia that as brief process, maybe a week or two, and that generally, you would think about potentially bacterial infections, more importantly, perhaps even candidal infections, as sort of generally endogenous organisms that we are colonized with that can sort of get into the wrong place, whether this is sort of, a pneumonia or UTI or even sepsis. But generally, we think of those as sort of the standard sort of, sick patient in a hospital presenting with those types of sort of more bacterial or candidal infections. Now, prolonged neutropenia then presents sort of as a different sort of a set of sort of things on your differential or risks. That's when you start sort of becoming concerned about one molding type infections like Aspergillus, Mucor, and other types of fungal organisms, as well as reactivation of different viruses, right? Sort of prolonged neutropenia, whether you're sort of latently infected with CMV or HSV or even VZV. So for example, this patient had an episode of shingles, which doesn't need neutropenia for it to occur, but certainly those things become more likely in that setting. In those with sort of from some endemic regions where there are different sort of sets of organisms, in particular parasitic infections, that also then presents sort of a concern as well, particularly with things like strongyloides, for example. So it definitely, the more prolonged the neutropenia, the more severe your differential broadens a little bit.
And in a patient with asplenia or presumed asplenia, what organisms do you think of in that standpoint?
Yeah, so that's a great detail, right? So the classic sort of concern about sort of patients post-splenectomy or a splenic would be with encapsulated organisms. So the general three that sort of you're worried the most would be pneumococcus, meningococcus, and Haemophilus influenza. And sort of you think about those because those are the ones that we have vaccines that can sort of, at least diminish that risk. So those would be the ones that you're mostly concerned about. But there's, but the list is also pretty long, right? Like you tend to think of sort of things a little bit more esoteric, like rhodococcus or even nocardia, also somewhat related to asplenic patients.
Lastly, in this patient who has sore throat, are there any no misdiagnoses that come to mind just with the idea of immunocompromise and sore throat? Are there any no misdiagnoses that come to mind?
Well, in this situation, right, you really want to make sure that you're not missing sort of a more suppurative infection, whether it's sort of an abscess related to Staph aureus, or something that, could be like a medical emergency, right? So that's an important part, like an epiglottitis, or even like a dental abscess, for example, that's now sort of going down into sort of different layers, in the neck, in fascial planes, I should say, in the neck. So those are sort of important considerations because it can happen very easily in these patients, and usually sort of the symptoms can be slightly more muted, right? Like a sore throat in a neutropenic patient could actually be sort of, a raging infection with lots of inflammatory symptoms in someone with an intact immune system, in particular with neutrophils. So that's sort of an important thing not to miss, right? So your exam, if they're presenting with sore throat, you want to be very thorough in your sort of oropharyngeal exam. Certainly thrush, right, and Candida esophagitis would also be an important element in your history and your physical. You're looking for those white patches in the tongue and in the buccal mucosa, as well as sort of in sort of further back in the posterior part of the oropharynx. And then that's when you want to associate that with dysphagia, right? Sort of the classic Candida esophagitis, sort of is solid foods. Are those getting stuck down your throat? And are you having actually difficulty swallowing? And then lastly, you can also be concerned about sort of atypical presentations of viral reactivation once again. So HSV, not only with esophagitis, but sort of other sort of ulcerative sort of presentations can present as just simply a sore throat. And that is on top of sort of community acquired type infections, right? Like, so could this be your typical group A strep type infection, or even sort of, respiratory community related viruses, whether it's rhinovirus, enterovirus, parainfluenza, you name it.
Dr. Paer, back to you.
All right, so heading into the next aliquot, I'm just going to round out the rest of her past medical history and get into some social history. So for the past medical history, you mentioned rheumatoid arthritis, Felty syndrome, pulmonary hypertension, but then two additional aspects of her past medical history that I wanted to very briefly highlight are number one, hypereosinophilia, and number two, lymphadenopathy. And I'm happy to fill in, more details if need be, but I'll just briefly say that the hypereosinophilia was attributed to her rheumatoid arthritis, her hematology actually. She had a negative inflammatory neoplastic workup, and as far as an infectious workup was just strong E antibody negative. For the lymphadenopathy, it was noted incidentally on her cross-sectional imaging as part of her pancytopenia workup. And I'll briefly mention that she was HIV negative, quant TB gold, and had a core lymph node biopsy that was negative for lymphoma, and there were no granulomas either. No past surgical history. Home meds, budesonide, formoterol, cetirizine, montelukast, metoprolol, metotentan, sildenafil, spironolactone, and furosemide. And notably, no PICC line with Remodulin, and notably no DMARDs or biologics. And then no known allergy medications. Her family history, her sister has rheumatoid arthritis. And for social history, she was born in Puerto Rico. She moved to New York City in childhood. She lives in an apartment in Manhattan with 3 children and 1 granddaughter. She works as a driving instructor. Her only known sick contact was her granddaughter, who was recently evaluated for an ear infection in the ED a few weeks ago, around the same time that she presented for the sore throat. No recent travel outside of Manhattan. She is not currently sexually active. no pets or mold in the house, and she did not report any interactions with animals nor any recent insect bites, and no prior or current smoking or illicit drug usage, just has a few beers on the weekends.
Jeff, can I ask you a few questions?
Of course.
Okay. Remind, so she's not on any immunosuppressive therapies, or what happened with the methotrexate? Remind me.
Yeah. So the methotrexate, she was last on it 2 years prior. And
she's currently not on any treatment for the rheumatoid arthritis?
That's correct.
Okay.
Yep.
All right. And when was the last time she went to Puerto Rico?
So I'm not entirely sure, but I believe it was on the order of like decades prior.
Okay.
She said nothing recent.
Got it.
Dr. Pereira, where's your mind at with like the initial presentation? And I was wondering, what social history do you think of when interviewing patients who are asplenic or neutropenic per se?
Yeah, absolutely. So to get at your second question, when I'm getting into the social history for a patient who's neutropenic or asplenic, I'm trying to get at possible exposures. So for the asplenic standpoint, I'm wondering, do they have any contact with animals or insect bites, like getting at, zoonoses, or, for instance, like misdiagnoses, if the was a patient, did she have, insect bites, was she hiking, et cetera? And then in addition, for travel history, thinking of malaria in an splenic patient, did she go to a part of the world that is endemic with malaria? And then I think those are the top things on my mind. Would love to hear Dr. Pereira's thoughts as well.
Yeah,
then,
I mean, it's sort of that social history. And one, it's always fun to hear people's stories, right? And it makes the case more relevant. You're certainly now more personal, it's a more personal now case to you as you get to know really, wonderful people throughout, right? So that part is but it's also enormously instructive, as Jeff said, in terms of what kind of exposures that person has sustained over their lifetime. And remember that when it comes to infections, it's not just recent exposures, but in many situations, it can be lifetime exposures, right? So it is not, I'm not being excessive when I say that, really everyone's infectious risk starts before they're born, but certainly after they're born. And, in many ways we carry, the places that we've been in our lives through the infections that we accumulate. So in her case, Puerto Rico is enormously important, right? Because you think about what kind of endemic organisms. So Jeff mentioned tuberculosis, certainly strongyloides, certainly malaria. There's not so much, right, in the Caribbean. I think Haiti is the only place that's left in the Caribbean, but certainly South America and other places of the world, there's plenty of malaria, right? The other often not talked about organism from the Caribbean will be histoplasma, right? All of these can be latent and can reactivate in the setting of immunosuppression, particularly prolonged immunosuppression, like I mentioned. So for someone like her, what's interesting, she certainly has been immunosuppressed for quite a while, right? Rheumatoid arthritis in and of itself is an immunosuppressive condition. Felty syndrome even more so because of the neutropenia for sure. Obviously, the medications that she has received then exacerbate that net state of immunosuppression. So you have a sense that, okay, she's been immunosuppressed for a while. If this was a remote exposure, like childhood exposure to tuberculosis, well, 10 years later, or 9 years later or so, is this about time that he would reactivate or so? Certainly possible, but with time it becomes less likely. Then you think about recent exposures, in particular her case. So she's a driving instructor. So imagine the numerous exposures that she gets on a daily basis, right? With people that she's trying to drive and she's in a car with someone. So if someone has a viral infection, easy to transmit. And then the interesting part of her granddaughter having an ear infection and the timing coincidental with the beginning of her symptoms, which are also in some ways respiratory, right? So she's having the hemoptysis, the dyspnea, epistaxis, the cough, and I think you mentioned the sore throat as well. So it certainly could coincide that maybe she got something from her granddaughter. So in some ways, that's what I'm thinking about. There's obviously all sorts of hobbies and other activities that someone people have that sort of potentially can expose them. So you want to know, like, I know in Manhattan, sort of people don't often garden, but elsewhere in the world, there's lots of gardening happening, and then you worry about sort of exposure to fungal spores or nocardia and things of that nature that could be reactivating or causing a primary infection. And then sort of what kind of foods does she eat? Does she like unpasteurized cheeses, for example? Maybe that's like a thing that she really loves. Makes you concerned about things like M. bovis or other sort of listeria, for example. So those are sort of in some ways, fun, esoteric, but also pretty important parts of your social history.
Dr. Pereira, would you be so kind to recap the case or give us a one-liner of the case so far?
Yeah, absolutely.
Mm-hmm.
So far, we have a 46-year-old woman with seropositive erosive rheumatoid arthritis, complicated by Felty syndrome and precapillary pulmonary hypertension, as well as past medical history of hypereosinophilia and lymphadenopathy, who is currently off DMARDs and biologics, who presents with acute-on-chronic cough and fever.
Can't wait to hear about the physical exam vitals.
Yeah, me too.
All right, let's get into it. So for this next aliquot, I'll discuss her initial vitals in the ED as well as her initial physical exam. So in the ED, she was febrile to 40.0 Celsius. That's 104 degrees Fahrenheit. She was tachycardic to 144 beats per minute, hypotensive to 89/56 with a MAP of 67, and tachypnic to 24 respirations per minute, and hypoxic to 94% on 4 liters nasal cannula. And on physical exam, she was ill-appearing, anicteric. She had crusted blood at the bilateral nares, no obvious purulence or ulceration or eschars of the visualized nasal turbinates, and no oral thrush. There was no cervical lymphadenopathy, no nuchal rigidity. She was tachycardic with a regular rhythm, a normal S1, a loud P2, no murmurs. She had crackles at the left lower lung base, otherwise was clear to auscultation. And her abdomen was soft, non-aesthetic, non-tender. She had hepatosplenomegaly and normal bowel sounds. Her extremities were warm and dry. There was no signs of tenosynovitis. And on a comprehensive skin exam, there were no rashes, no Janeway lesions or Osler nodes. And her neurologic exam was notable for lethargy, but she was easily rousable and would sustain attention thereafter. Was grossly non-focal.
Dr. Pereira, what are your thoughts when seeing these vitals and exam, and what are the next best steps that you think of?
Well, and this is where you immediately triage the situation, right? And sort of the obvious initial question one should always ask, sick or not sick? And she meets almost every criteria for actually really sick, right? So sort of high fever, tachycardia, obviously hypotension, tachypnea, hypoxia in someone who's immunocompromised. So this is where, you as a medical student or intern or even approaching this patient in the ED, this is where you start thinking about who you're going to call to help you triage this patient. Is this someone for the floor, step down, or ICU, right? So sort of first things first. And this is where you think about, again, sort of in terms of your quick differential, right? So someone mentioned on the list here, sepsis, right? So we're talking about all of these potential fun, different organisms and pathogens that could cause sort of a presentation like this in an immunocompromised patient. But sepsis, obviously, from any kind of gram-negative or gram-positive organism ought to be pretty high on your differential here. You can sort of ask later, where did it come from? But certainly you want to consider sort of sepsis management in a patient like this, sort of your priority. And then sort of, as it is often with these cases, right? Like the exam helps you in some ways, but not really, right? I guess the crusted blood and bilateral in the bilateral nares, well, is this the epistaxis? And why is she having that? Is this part of her rheumatoid arthritis or Felty syndrome, or is this sort of, some kind of sinusitis that now you're sort of, it's being manifested that way? It's not often that it's bloody, but certainly can be, in particular, if it's erosive. It looks like her oropharyngeal exam is pretty unremarkable. She does have obviously some abnormalities in her lung exam, and she's lethargic, but easily arousable, but certainly the lethargy is concerning. So is there sort of a CNS type process, right? I don't think, did you mention anything about nuchal rigidity, Jeff?
Yes, no nuchal rigidity.
Okay, good. Okay. And no rashes. So that's good, right? Like, so obviously, like with things like meningococcus, you want to make sure there's no like disseminated petechial lesions. So this is someone that you initially want to sort of start a very broad workup, and you certainly start with the basics, right? I can't wait to see the chest X-ray and obviously the basic labs in terms of what abnormalities are present. But this is where you fire off like blood cultures, urine cultures. If you can get a respiratory culture, surely you can do that. And potentially then consider if you're that concerned about CNS infection, is this a case where you want to proceed with a lumbar puncture as well? And then shortly thereafter, your sort of initial workup, this is where in someone like this, certainly sort of your sepsis protocol in terms of broad empiric antimicrobial therapy. And, it pains me to say because, your stewardship is very important, but this is someone who's sick. But let's see the labs first. And I don't know if there was anything else here.
Dr. Peer, back to you.
Okay. So for this next aliquot, I'll provide the lab and imaging results as they became available to the providers in real time to try and simulate the real world flow of data in this case. So there's some suspense here, but it's not intentional. I'm trying to simulate the real world experience. So on her CBC, her white count was 2.7, which is low. Her ANC was 1,400 cells per microliter, and this is still low, but this is increased from her last ANC value, which is 320 about 1 month prior. Her hemoglobin was 10.5, and her platelets were 166, which is the lower end of normal, and previously had been below the 150 threshold. Her peripheral smear was without schistocytes, but there was no comment regarding the presence or absence of Howell-Jolly bodies, and there was no comment regarding the presence or absence of intraerythrocytic parasites. On her BMP, her sodium was 141, her K was 3.5, her chloride was 101, bicarb was BUN was 12, creatinine was 0.6. The anion gap was 16, glucose 93, magnesium 1.7, phosphorus 1.6. On her hepatic panel, her total protein was 8.7. And her albumin was 2.3. Her total bilirubin was 1.2. And her direct bilirubin was 0.6. Her AST was 73. And her ALT was 51. And her alk phos was 123. This was all grossly at her baseline. Her coags, oh yeah.
Sorry, I don't know. Is this the right time that I can ask a few questions about this? Or maybe you should keep going and then I'll ask you some questions. Sorry.
Okay. Feel free to interrupt at any point. Okay. On her coags, her PTT was 40. Her PT was 20. And her INR is 1.7. And these were also grossly at baseline. And her fibrinogen was 295, which is normal per hour assay. Her venous blood gas was 7.50, 31, with a lactate of 2.4. Yep. And her pro BNP was 140. Her pro calcitonin was 0.2. Her ESR was 28. Her CRP was 18.4. Her urinalysis was non-inflammatory. Her respiratory pathogen PCR panel was negative, including COVID. Her Legionella urine antigen was negative. HIV negative. Hepatitis B. Hepatitis C antibody positive, but NAT negative. Her 1,3 beta D glucan 83. Okay. And her EKG revealed sinus tachycardia, normal axis, non-specific T-wave inversions, but no diffuse PR depressions or ST elevations. Her chest X-ray noted pulmonary edema and bibasilar opacities. The ED team obtained a CTPE study. And I'm not quite sure why, but I imagine just with the acuity and how sick she was, I imagine they acted quickly without taking a very thorough history, and just wanted to take PE off the table is what I imagine. There was no PE, but what it did demonstrate was left lower lobe and to a lesser extent, right lower lobe consolidative opacities, ground glass opacities in the lingula and peripheral right lower lobe. No pleural effusions, no pneumothoraces, and she did have sub-centimeter mediastinal and hilar lymphadenopathy, and was once again redemonstrating splenomegaly. And I'll just up with her course briefly. So she was pan-cultured, started on empiric vancomycin and piperacillin tazobactam. She was triaged to the ICU for fluid unresponsive shock requiring vasopressors and close monitoring of her respiratory status.
Dr. Pereira, question from the crowd is, which antimicrobials would you have chosen for this patient, and why would you choose every agent per se?
Yeah, no, that's always an important question. So I think that, you certainly want to cover for your typical gram-negative organisms or Klebsiella, E. coli. I think in this particular case, the question of Pseudomonas can certainly be debated. But in someone like her that probably has seen a lot of hospitalizations and certainly some exposure to the sort of healthcare system, certainly one could consider Pseudomonas, particularly as she's presenting with a potential respiratory organism. So Pip-Tazo seems like a reasonable choice here for broad spectrum. Other choices like cefepime would have been fine. We're a particular center that likes and continues to use Pip-Tazo. And then as far as the vancomycin goes, I mean, that's certainly more debatable. I think that here I see it being used quite often, and there are times when we panic and we use it as well. We're sure to make the recommendation. It's obviously the MRSA question, does she have it? And maybe there's something here that we don't know, that she maybe was previously known to be colonized or not, but certainly presenting with a pulmonary infection makes you concerned about Staph aureus, period. Now, whether this is MRSA versus MSSA, it's a little bit more difficult to tell. Our neutropenic sepsis guidelines don't always mandate vancomycin. So this might have been sort of more of an ED sort of management plan, and and then leaving sort of more nuanced thinking for the medicine team admitting the patient. And people might decide to discontinue the vancomycin. Obviously you can get the MRSA swab, and if that comes back negative, you can discontinue it more safely as well. So that part I think is okay. I don't have any issues with that. And I think many of us would have done that initial sort of type of management here. Certainly there's not a lot of role for empiric antifungal coverage, right? I think very few people in the absence of some further data here, would not necessarily start the patient on a kind of Candin right now, or even like an anti-mold sort of process, unless you have more evidence sort of suggesting that way. The beta-glucan, it doesn't come very rapidly, so usually it takes a day or two for you to get that. And at 83, it's a pretty underwhelming value for Candida. Antivirals sometimes can be considered, but it's sort of not something that you also start empirically, unless you're worried about an encephalitis, and in which case then acyclovir gets added, right, to sort of your empiric meningitis regimen. But I wouldn't start that here. Not that viruses are not part of my differential, but you wait for some more evidence of that.
Oh, that is very helpful. And how do you frame this patient, and what syndromes are you thinking of at this point in time?
Yeah, I mean, I think in some ways the differential remains quite broad. Obviously being organism skewed by sort of, okay, well, this is a presentation, right? it's probably not, E. coli bacteremia translocating from her GI or like a pneumonia. But certainly I think that, on a purely sort of common things being common, this is what you have to consider. Interesting facets here. Obviously, she is somewhat neutropenic, and her protein gap is quite significant. I don't know if that's part of her underlying disease or not, but certainly sort of quite significant, And then the only going into sort of more esoteric things, you certainly continue to be worried about bacterial organisms and those that are sort of less common. I think Legionella, despite the urine antigen, you could be concerned about that. I mean, the Legionella is something that can make one pretty septic rather quickly with sometimes underwhelming respiratory sort of findings, although hers are not underwhelming. In particular, sort of with that CT sort of showing consolidative opacities and a combination with ground glass opacities, certainly you want to consider sort of atypical organisms. So Legionella, Chlamydophilia, and Mycoplasma. Her LFTs, I guess, obviously they are abnormal. It sounds like they are somewhat at her baseline, so not particularly helpful. She had a negative Strongylm antibody at some point, but we actually had seen cases of someone who had a negative serology test, but still have sort of just, a sort of a disseminated strongyloidiasis. So that's an important aspect here. She does have this hypereosinophilia that's not otherwise explained, it seems. And like with any serological test, these are not 100% sensitive. So you do want to sort of still keep potentially a parasitic organism in your differential. As far as viral organisms, obviously with the negative RPP, you sort of ruled out influenza and the other community acquired organisms that we talked about earlier. Again, she's immunosuppressed, so could CMV be reactivating here? And maybe this is sort of more of a pneumonitis type picture, again, because of the ground glass opacities. Certainly something to think about. There are other viruses that can do that, but CMV would be one to be concerned about. I certainly have seen CMV reactivate in cases of rheumatoid arthritis, usually with some degree of immunosuppression in terms of medications, but certainly could happen here. TB, I guess, we have not ruled out TB yet, or at least we have to consider it in some ways. Histoplasma, it'll be interesting to ask you, Jeff. So the CT, these consolidative opacities, were they nodular in sort of appearance? Did the radiologist mention anything? I wish we could see it, but if we can't, maybe you can guide us a little bit through what they found.
Yeah, so definitely not nodular. It was just quite consolidative.
Okay.
I did send the team just a picture of the perfect cross section from the CT chest to look at. I'm not sure if they're able to very briefly put it on the screen, at least for those tuning in now to see for themselves. Okay.
We can definitely try to add it, and just give us a few moments if you can continue the
and I can keep talking.
Discussion.
So what's interesting is you have a mixture here of consolidation and ground glass opacity. So could these be related? Could there be some sort of pulmonary edema on top of a consolidative infection, right? So, but maybe not, right? So certainly mold infections here can present with sort of this combination of ground glass opacities and consolidative patterns, usually nodular, like I asked. So it seems less likely, but you still want to consider potentially even aspergillosis in a case like this, although you don't get this septic, with an aspergillus. Usually these are indolent respiratory infections with fevers, cough, maybe a chest pain when you cough, or like a pleuritic type process. But this seems a little bit too much for a mold type infection. Nocardia certainly could be, depending on sort of how these consolidations work. Usually they have sort of this surrounding ground glass opacities or sort of, inflammatory process. So something to consider. And now sort of all the associated sort of, gram-positive rods as well. So let's take a look here. I can see the CT.
Dr. Pereira, if you can please describe what you're seeing on this cross section. I know it's just the cross section.
Yeah, I mean, I can see sort of clearly sort of, left lower lobe, dense consolidation. I think those sort of things are air bronchograms that, if you were to go up and down on the cross-sectional imaging, those might look like air bronchograms. I can't really tell. It doesn't seem like this is sort of an abscess with like air fluid levels from what I'm seeing over here. I do see some surrounding sort of ground glass types appearances, in particular, sort of at the more medial aspect of this deep consolidation. I'm also seeing something on the right lower lobe in terms of a consolidation there as well. Not a lot of pericardial effusion. The rest of the parenchyma, it looks okay to me. You know, I don't know if that's necessarily, I'm looking at sort of ground glass opacities from this one shot, but clearly there's sort of it's a multifocal pneumonia in terms of what I'm seeing. So, you know, the other thing is, so immunocompromised individual presenting with hypoxia, you know, you certainly think about pneumocystis, right? The degree of hypoxia here doesn't seem to be as high, or at least sort of concomitant with how sick she is. So I will consider it, but not put very high on my differential. The beta-D-glucan coming back at 83 makes it less likely, but certainly something that in the beginning you would have considered. And then what else am I missing here? We talked about sort of fungal organisms, parasitic, bacterial, atypical organisms, certain viruses that I would include. I said atypical organisms as well. You know, mycobacteria, I think to a certain extent you want to consider. And then the last one was histoplasma, right? So the comment that I wanted to ask you, Jeff, is sort of, you know, she has splenomegaly. Were there calcified lesions in her spleen at all?
No, never with calcified
Okay.
lesions noted on imaging.
Okay, all right, it's fine. So histoplasma as an endemic fungal organisms, you know, you can sort of have calcified lesions from prior exposures or from like sort of early on infection that subsequently then reactivates. But histoplasma would certainly be sort of a consideration here. It can cause a beta-D-glucan to be positive as well, but you know, these things are not again 100% specific or sensitive.
Dr. Paer, back to you.
All right, so Dr. Pereira, do you want to put, you know, stake your claim and say what you think the diagnosis is? Because this next aliquot will reveal the diagnosis.
Oh, okay. Oh, well.
Or I can go through it. I can go through it.
I would love to come up with something. Well, I don't know. I mean, I maybe I'm going to stick with histo. You know, she does have sort of this, you know, prolonged neutropenia, and I know that you can explain in other ways, but maybe a consideration for histoplasma here.
Okay. All right. So I'll read the data once again as it flowed in real time to us as the team. So a stat echo was done when she was in the ED just because of her shock and her pulmonary hypertension. And so her echo noted preserved biventricular function, no new valvulopathy, but she did have a new small mobile echo density attached to the ventricular side of the aortic valve.
Oh, okay.
And right, and so the blood culture, and then shortly thereafter, the admission blood culture is one of two bottles on gram stain, gram positive cocci and pairs and chains.
Okay.
And ultimately speciated to Streptococcus pneumoniae via biofire. Yep. And around the same time, sputum culture comes back with just oropharyngeal contamination. And so ID was consulted at this point. Antibiotics were switched from vancomycin, piperacillin, tazobactam to vancomycin and CNS dosing ceftriaxone. And an LP was performed with the following CSF studies. And notably, this was on 48 hours post antibiotic initiation. CSF, 2 white cells, 0 red blood cells, a protein 16, which is normal, level of 85, which is high, and the meningitis encephalitis panel was pan negative, including the Streptococcus pneumoniae primers, and culture was negative.
Wow. Dr. Pereira, you mentioned this diagnosis in the first or second aliquot back when we were talking about sore throat. And what would your reflection be on this case, or how would you frame it for us?
Yeah, you know, it's sort of, you know, the the typical life of an infectious disease doctor, right? Like, so you think of your sort of your foundational things, right? It's sort of like common things being common. You always want to really make sure you're not missing those things. And then you venture out into esoteric things. In particular, someone whose world is as skewed as mine with transplant infectious disease, you're always looking for those zebras or those reactivations, but you want to cover your bases, right? So you want to do the proper initial workup because, again, you don't want to miss the more common things. So this is obviously a classic case of strep pneumo in someone who is immunocompromised and asplenic, right? So it would be interesting to know whether she was vaccinated or not. But it obviously clearly fits the picture. And even that sort of, CT imaging, obviously multifocal pneumonia secondary to streptococcal pneumonia can absolutely look like that, and it often does. So, and I think that in some ways, the fact that, we triage the patient correctly, this is someone sick, and you do want to treat them broadly with antibacterial agents that will cover these sort of pathogens, I think sort of, it allows you to then focus on those other sort of more esoteric type things, and once you find something sort of common and sort of so classic, you've still done some good. Right. So I'm happy that, we were treating this patient appropriately from the very beginning. And, and I think that that's the important message here, that sort of you're thinking about the things that are common and can certainly cause very severe illness. Very interesting. And I guess the mobile echo density on the echo. So, all right, so we might be concerned now about infective endocarditis, or so she has pneumonia, infective endocarditis. Doesn't sound like she has meningitis. So somebody had mentioned here Austin's triad. But certainly I think that, she probably warrants some further workup here and make sure that this is not infective endocarditis, which likely is at this point.
Dr. Pereira, would you guide us to what happened next?
Yes, absolutely. But before I get there, I just wanted to ask you a quick question, Dr. Pereira. So two quick questions. Number one, how do you interpret CSF studies when sampling occurs after several doses of broad spectrum antibiotics?
Yeah, it's sort of, you probably have about 24, 48 hours to still have, at least from a microbiological perspective and even from a sort of profile, to get something interpretable, right? The issue is always you want to rush to obtaining that sample is for the cultures. You can sterilize the cultures very quickly for certain organisms. Now that's a little obviated with the meningitis encephalitis panel, PCR panel, which can remain positive for a much longer period of time for most of those pathogens. And in fact, it's so overly sensitive. We've all seen the pitfalls of PCR testing in terms of measuring dead organisms or detecting dead organisms, but nevertheless, it's sort of important. As far as sort of the profile, it's I think that the more interesting question is that she's sort of, neutropenic, right? In some ways she is. So to what degree is sort of 2 WBCs here significant? I think it is. I mean, I think she does have enough neutrophils here that you would expect her to mount sort of at least 10 WBCs in her CSF. So I think that's important. Her protein in some ways then becomes a marker, right? And her protein is normal. She doesn't have sort of elevated protein or a low glucose here to suggest meningitis. And your exam was not impressive for it, right? Like how you had mentioned earlier, the lack of nuchal rigidity. So I think that this is consistent with not being a meningitis. So if someone were to ask you, well, what dose of ceftriaxone, right, do you want to treat this patient? I think you can just treat her systemically and not with CNS sort of active dose.
Got it. And so that came to my second question, which you already partially answered, which is in a febrile, neutropenic, and functionally splenic patient, does the presence of meningitis really change your management in any way other than just antibiotic dosing? Or at what point would you start to bring in the question of steroids?
Well,
if the patient did have meningitis
recently, right? I think there are more studies now suggesting that actually steroids are quite helpful, not only for sepsis, but for meningitis as well. So this potentially, if you had a greater concern at that upon presentation that she had meningitis, this probably would have been a patient who would have potentially benefited from steroids. So it's been shown, I think, now to help with strep pneumo, So I think that this would have been something that you would benefit. Now, 3 days into her hospitalization, now you obtain an LP, and it's suggestive of meningitis. I think that's a different situation. You know, you've already seen antibiotics for over 24, 48 hours. I think the utility of steroids in that situation is a little bit different. So it's sort of ER versus, you know, inpatient sort of management that are very different when it comes to steroids.
Got it. Okay.
Yeah.
Alrighty. So for this last aliquot, I'll just briefly mention some patient course information, and then talk about one final bit of data. So her isolate was ceftriaxone sensitive, and so she was narrowed to ceftriaxone monotherapy. And after 24 hours, her blood culture is cleared. Within 48 hours, she's weaned off vasopressors and oxygen. She was seen by ENT, didn't undergo flexible nasopharyngoscopy. They felt it was related to her coagulopathy. And then she did obtain a TEE, and it redemonstrated a thin filamentous echodensity on the ventricular side of the aortic valve, possibly consistent with Lambo's excrescence versus a degenerative fibrous band versus a vegetation. And notably, there was only trace aortic insufficiency and no other valvulopathy. And just in my own brief reading, a Lambo's excrescence is a small fibrous strand located on the cardiac valves that are made up of fibroelastic tissue with an avascular core. They're covered by an outer layer of endothelial cells, and they're thought to be formed by shear forces to the endocardium of the valves, and forms most commonly at lines of valve closure. And there is a theoretical but very low incidence of embolic stroke. So usually these are just noted incidentally, and nothing is done about them, per my reading. In any case, cardiac surgery was consulted, and they deferred intervention given the atypical small AV vegetation without significant AI. And that service as well raised concern for perhaps an alternative explanation of non-infective endocarditis in the setting of rheumatoid arthritis or this Lambo's excrescence.
Dr. Pereira, did we reach the final diagnosis at this point, from your standpoint?
Yes. So the final diagnosis was invasive pneumococcal disease with AV endocarditis. You know, sort of despite this discussion regarding the small, thin, atypical AV vegetation, just given her neutropenia, her functional asplenia, we had to, commit her to a long-term course of antibiotics.
And that's a wonderful case. Dr. Pereira, what would your take-home points be from this discussion and this particular case?
Yeah, I think it's sort of important to always think about the basics, right? Even at this day and age, even when there are effective vaccines, it takes people to take those vaccines. And also if you are immunocompromised, maybe those vaccines don't necessarily have the same efficacy as those who are non-immunocompromised. So this will be interesting whether, she was vaccinated or not. It's sort of immunocompromised patients, the challenges of diagnosing them and sort of the thinking through those cases is that not only they have, again, unusual and opportunistic infections that you have to consider, but also the common infections that sometimes sort of are so, apparent that you can even sort of, oversee those things. So it keeps you on your toes for sure. And I think that this is one of those cases for sure. I think that, if one had masked her, immunosuppressive history, right? If this was just a 46-year-old woman with a history of, I don't know, you name it, just hypertension, if she's presenting with this, I think many would have said strep pneumo much sooner, than otherwise, right? But that's an important lesson, right? That we have to think of all of these sort of organisms when it comes to a patient presenting like this.
Thank you both for this amazing discussion. And I think we really learned a lot about the approach to pulmonary infiltrates, an approach to neutropenia, asplenia, and infectious syndromes in general. Thank you for joining us, and we would love to have you again in the future if you all are interested. And thank you everyone for joining.
Yeah, wonderful. Thank you. Thank you for inviting me.
Thank you all. Thanks for having us.